Okay, so what we are doing, I kind of had to chop things up because, sorry, Sean, yeah, I don't know what happened with the previous link. It wasn't opening for me, so I had to make a new link and you guys could get in it, which I'm not sure why that happened, what happened to my Zoom. So sorry about that. Sorry about the confusion. I just uploaded. So the next thing that we would do if we had a whole week, we would be doing anesthetic equipment. Since we were just talking about inhalants, I just uploaded this as chapter 4, which is anesthetic equipment, and I'm gonna talk about just the vaporizer part. So that's what we will talk about. And then we will do the full anesthetic equipment week 1 of anesthesia 2. So you'll have a little bit of it. But first I want to show this picture. Now, again, I haven't gone over a full anesthetic machine with you. But this is kind of a spread out diagram of the flow and all the parts. Kind of like what we're going to end up doing when we do equipment is we're going to do the flow of oxygen from the tank to the patient, how it leaves, almost like you're doing blood flow through the heart, and what are the parts along the way. The reason I'm showing this now is I'm talking about the vaporizer first, and there are 2 types of vaporizers, which were called, precision and non-precision. Precisions are also called a vaporizer out of circuit, and I want to explain what that means. When we talk about the circuit, the anesthetic circuit is where the animal breathes from. It's the tubing where they inhale and exhale the gases. Now, in the current machines that we have at school and that we use with the current agents, you need to use a precision vaporizer out of circuit. And so here, what I'm pointing to, actually, let me blow this up a little bit. Maybe it'll, actually it was bigger before, but what we're looking at here is this is the breathing circuit. Okay, so oxygen comes into the patient here. The Y piece is what hooks up to their endotracheal tube. They inhale, and then when they exhale, it goes out the exhalation tube and it leaves the system. The vaporizer out of circuit is over here. And so when you set a out of circuit vaporizer, if you say you have a vaporizer on 2%, it's going to deliver a consistent level of 2% anesthetic into the circuit. But that amount never changes unless you change it. It's out of the circuit. When we used to, and here's a note here about a vaporizer out of circuit, which is also known as a precision vaporizer. The old anesthetic vaporizers that were used a long time ago were called non-precision vaporizers, or they were a vaporizer in circuit. And the vaporizer was usually somewhere near the inhalation valve, which is right here, meaning when the patient breathes, it's breathing, the vaporizer is attached within the circuit. And that's the difference. So when we talk about a VOC, and I'll use the abbreviations, VOC is vaporizer out of circuit, VIC is a vaporizer in circuit. And that's just where is the vaporizer located in like this diagram. Ariel, it's not your fault, sorry. I couldn't get the old Zoom to open for me, and I thought the link had expired, so I made a new code. So everyone is fine. Hopefully everyone will get the message and come over. So I'm still missing a few. So let me skip ahead to the part about the actual vaporizers themselves. Okay. Okay. So this starts on technically slide 43 of, yeah, if someone could send Ireland a message. I mean, I posted on Facebook and sent an email. So if someone can, I know someone, Emily messaged people that we were in a different Zoom, but this is being recorded. So, Okay, so the main gist of what the vaporizer does is it converts a liquid anesthetic into a gas state. And when it's delivered to the patient, it's delivered via a gas. Okay, so we don't use, so you pour the liquid into the vaporizer and then it will vaporize, and that's what's delivered. And the goal is to deliver a controlled amount, an amount that we have control over, that we can turn up or turn down, and control our patient. Now, there is an inlet and an outlet of the vaporizer. At the outlet is where the gas is going to leave and go to the patient. So when the gas leaves the vaporizer, it's called a mixed gas. So it's a mixture of oxygen, which is the carrier gas, and vaporized inhalant. So it's a gas mixture. And once it enters the breathing circuit, it is a set amount. You set the percent to be delivered to your patient, and it's a consistent level. And then I'm going to talk about the flow over vaporizers, which were the old ones. So if we look at this picture, so this is what a vaporizer looks like. You can say it says use only isoflurane on it, which is, it's also in purple because it is purple coated. And letter A right here, this first hose, if you see there's a black tube under here, that's what brings oxygen, and it comes into what's the inlet of the vaporizer. So at the inlet, you have oxygen. There's a little button here, which is letter C, and that's what you push down to turn your vaporizer. It's normally locked. You have to push that button down and turn at the same time. And you can see the picture's a little small, but these are also in your book. It is set at 2. So right now this vaporizer is set at 2%. And then letter B, this is the outlet of the vaporizer. And you see there's a black hose. This black hose would be going to the breathing circuit. So at letter B, which is the outlet, you now have oxygen and inhalant. At letter A, you only have oxygen. Now, in any clinic, you can use your anesthetic machine to just give your animal oxygen. If you have an animal that comes in and they're having a hard time breathing, you could pull the machine over, make sure that this is off, in the off position, and if you turn on the oxygen, oxygen is going to go through port A to port B, but it will only be oxygen, okay? So as long as the vaporizer is off, it's not delivering anesthetic. But if this is left on, and that's been a mistake people have made. Sometimes people disconnect the patient and forget to turn things off. And then someone goes to grab that machine and hooks up oxygen. It would run anesthetic gas. So when you're done, you always want to make sure that this is in the off position. Because a lot of clinics will use their anesthesia machine to deliver oxygen in an emergency setting. Okay. So you've got oxygen comes in here, comes out the outlet of the vaporizer here. Now letter D down here, there's like a little window. This is where you see if your vaporizer has anesthetic. And if it's hard to tell, there's a line that says empty at the bottom and full at the top. And so that's where you check to make sure you have anesthetic in your vaporizer. Letter E, there's a knob here that you untwist, and this is where you fill the vaporizer. Most of the bottles of the inhalant have a little spout so that you can pour it directly into that port. And what you do when you pour, you have to watch, because you don't want to overfill it. If you overfill it, it can cause backflow in the vaporizer and could damage the vaporizer. So you only want to fill it to the top. Now, how long it lasts you, it depends on oxygen flow, size of patient, length of procedure. But all I do is, I mean, it can be full for a week, depending on how many procedures you do. There's no good way to say, because the more oxygen you run, the faster you're going to go through your anesthetic. So it's variable. But all you want to do as an anesthetist is periodically, check your window. If it's full, you should be fine for procedures, but definitely you want to make sure that you have anesthetic. I have had patients, when I was at Purdue, and all of a sudden they're like, my patient's waking up, and then I look at the vaporizer, I'm like, you ran out of anesthetic. So right now your patient's only getting oxygen. So you have to be careful. So this is the standard vaporizer. They can look a little bit different design, but they all have an inlet. They all have an outlet. They have a button that opens the dial, and then they have a fill window and an area where you fill it from. So even if they look a little bit different than this, they have a color code for the anesthetic, they're labeled, and they have all the basic parts. Now, the two types of vaporizers were your non-precision and your precision vaporizers, but your non-precisions were used a long time ago with your low vapor pressure anesthetics. So that was that would have been your methoxyflurane, and it could also be used with halothane, but methoxyflurane, and this is why this was used a long time ago. And I don't think any of you on externship would use it, because technically non-precision vaporizers, the current agents that we have available have high vapor pressure and they need a precision vaporizer. It's not safe to run a non-precision vaporizer with ISO or SIVO. So when I taught at the school, it was like 11, 12 years ago. Well, Sipes was a student of mine. Sipes was in the very first class, and I taught them anesthesia. And of course, Sipes goes to some country clinic out in the middle of nowhere, and she ends up sending me an email. She's like, we have a non-precision vaporizer. I'm like, of course you do. And, you know, they kind of got it to work. It's just not recommended. It can be very dangerous. So, you know, unless you're working out in the middle of nowhere, very old clinic, you might see sometimes clinics have a machine shoved in the corner they don't use anymore. You might see it, but it's just not currently used. Precision vaporizers can deliver a precise amount. That's the benefit, is that they are used for high vapor pressure anesthetics, which is isoflurane and sevoflurane. Because those agents, remember, high vapor pressure means the likelihood it wants to turn into a vapor. And because they have high vapor pressure, we need to control their delivery. And so you have a lot more control. A perfect teacher question is, what type of vaporizer does the anesthetist have control? Better control of their patient. A precision vaporizer. Think precise. So here's a picture of, okay, I just went over a precision vaporizer with you. Here's the non-precision vaporizer. And I know I haven't completely gone through machines, but in this picture, you have these two black tubes. One of these tubes is the inhalation tube, and oxygen and anesthetic, I'm sorry, it would be this one right here. Oxygen anesthetic go to your patient, and when they exhale, it comes out this other tube, and then the exhaled gases leave. And this is the circuit. But you can see attached to the inhalation valve is this jar, and if you can see this like cream colored, that's a wick. It's like a cloth wick. And so you would take this jar off, fill it with your anesthetic, and there is a valve up here. I don't know if you can see, there's like a little round thing with a pin, and you would turn just like an oil lamp. So if, for example, and there's a lot of notes under here about these vaporizers, but what happens here is if your patient was getting light, you know, starting to move, you would take that little knob at the top and open it up a little more, and then more anesthetic would wick up that cloth. And then as your patient inhales, if you could imagine here, oxygen is coming through this inhalation valve and is going through the jar. As the patient inhales, they pull oxygen through that jar, which picks up the vapor, and then they inhale it. But if you think about it, because this is in the inhalation tube, or it's within the circuit, the patient's respiratory rate and respiratory drive can affect the anesthetic concentration. Again, if their respiratory rate goes from 20 breaths a minute to 40 breaths a minute, what do you think is going to happen if they double their respiratory rate using this non-precision vaporizer? What do I
When
worry?
they hyperventilate?
So they're hyperventilating. What would it do to their anesthetic concentration?
It's going to double the concentration?
Essentially, because they've doubled their respiratory rate. Do you see how, like, and then if your patient dramatically stops breathing, right, all of a sudden, and now they're not pulling as much oxygen through that jar, they could potentially get light or decrease their concentration. So as an anesthetist, you don't have as much control because their rate of breathing is going to be, they have access in the circuit. So a non-precision vaporizer, and what's not showing in this machine or this picture is letter B is your outlet. This is where oxygen anesthetic, it goes down this black tube and it would go into the circuit. But when the animal breathes, the vaporizer is out of the circuit. So they can breathe 4 times a minute, 20 times a minute, 40 times a minute. It's not going to change the flow because you are controlling the amount via this tube that goes into the circuits. And that's the big difference with the precision versus non-precision. Again, this is where is the vaporizer within the diagram with, and again, here's a better kind of explanation. So right here, VOC is a vaporizer out of circuit. It's not in the breathing circuit. Oxygen goes from the flow meter into the vaporizer, then it goes from the vaporizer to the breathing circuit. And this is why they're called precision vaporizers, because you can deliver a precise amount. There's a high resistance to gas flow, meaning it's being delivered outside of the circuit. And there's no way the patient's going to be able to pull from that vaporizer due to the resistance. Now let's look at the VIC, which is what I just talked about. A vaporizer in circuit, the oxygen enters the circuit from the flow meter, but then the exhaled gases pass through the vaporizer. And what happens is they can pull through this system. So the patient, because of where it's located, let me show you. Here's a picture. Again, so here's the VOC. They've taken some of those other parts out of the picture. So you have vaporizer delivering the anesthetic into the circuit. And this is where the animal inhales and exhales from. In the VIC, you have the vaporizer in the circuit. So when the patient begins to breathe, they can pull gases through that vaporizer and change their concentration. The only thing you have control over is that little valve where you can open and close it. So you have a little bit of, you can try to open it, close it based on your patient's depth, but their respiratory rate and how deep they're breathing can affect the concentration. So that's the main difference. Now, how much is coming out of the vaporizer? Well, normally you set the percentage, and that, what you set, we're assuming if you have the vaporizer at 2%, we're assuming the patient's getting 2%. And we can control this. Now, let me make a little side note. Your flow of your gas through the vaporizer can affect the concentration in both vaporizers. And follow me on this. You just have to conceptualize this with me. Normally, we run 1 liter of oxygen a minute to our patient. We set our flow meter and it delivers a liter of oxygen, and that keeps the bag full and the patient can breathe and goes throughout surgery. Sometimes if I want to make my patient deeper, I don't necessarily always have to turn up my vaporizer. Sometimes if the patient is breathing a little more often and the bag is getting smaller, sometimes I'll turn up my oxygen flow and I'll go from 1 liter to 2 liters of oxygen. So, okay, I've doubled my oxygen flow. So I am effectively adding more gas because the higher my oxygen flow, it's going to put more, a bigger volume of anesthetic in the system and in the bag. Now, it doesn't necessarily, it doesn't double. If your mind is thinking, okay, you doubled your oxygen flow, you double your percent. Well, I'm still at 2%. I haven't increased my anesthetic delivery, but I have added more of that 2% to the system. And that's just what it's saying here is your gas flow can influence the concentration. So if I go from a 1 liter flow to a 2 liter flow, I can increase the concentration that's in the system. Now there are times you do have to turn the patient up when they get light or they're moving. I do, but there's times where my patient's just a little light and I'll maybe do like a little bit of an increase in just the flow rate, and that's the only thing that I adjust. The other thing that factors into the vaporizer is the temperature. Now, the precision vaporizers that we use internally have a temperature control. So they're supposed to keep it at a consistent temperature because remember, temperature affects how something turns into a vapor. Remember I told you guys, I said, what if I opened a bottle in a cold room and a hot room, which do you think is going to vaporize faster? Well, you guys all said the hot room. And it's like, yes, the warmer it is, it's going to increase that vapor. So that's why the vaporizers are controlled to try and keep them a consistent temperature. But the ambient room temperature, the temperature around them, can affect it in extreme situations. I gave you that example of my friend's clinic that was having trouble keeping their animals asleep. And when they tested the temperature in the OR and of the vaporizer, the room, it was too cold and it was affecting the vaporizer. And so they had to adjust the temperature in the OR and fix the vaporizer. So ideally they're temperature controlled. But again, if you were in a very, very cold environment or a very, very hot environment, that could affect the percentage. And then the temperature of the carrier gas. Now, oxygen is cold. And, usually little patients on a high oxygen flow, I worry about hypothermia because oxygen is cold when it goes to the patient. Now, ideally, when the cold oxygen goes through the vaporizer, the temperature is controlled. That shouldn't affect the rate as much, but we worried about that with the non-precision vaporizers. Because if I go back, this is just a jar. It's not insulated. So in this, cold gas coming in plus a cold room could affect a non-precision vaporizer more than this is insulated and temperature controlled. So there is that's where the main difference when I talk about temperature is. And then I just talked about, oops, wrong one. Okay. And then respiratory rate and depth. Only in a non-precision vaporizer does that affect the concentration. Because remember, if your patient starts breathing rapidly, they're going to pull more anesthetic to themselves. They can increase their depth. And on the flip side, if they stop breathing or their respiratory rate drops dramatically, they're not taking in as much anesthetic. And so respiratory rate and depth can have an effect. If you have a patient that's breathing 12 times a minute, but they're breathing very shallow, they're not taking very strong breaths. They're not pulling as much oxygen and anesthetic through that jar. So you can, in effect, pull more, or the respiratory rate. But that's only with a non-precision. With a precision vaporizer, the respiratory rate has no effect on the concentration. That's all because it's out of the circuit. It's not within. Now, sometimes back pressure can affect the concentration. when you manually ventilate, but that's more with your non-precision versus your precision vaporizer. So the main thing I want you guys to know is about the temperature, the respiratory rate and depth, and the differences between a precision and a non-precision vaporizer. Now the color codes here, the ones that I wanted you to know was ISO is purple, SIVO's yellow, halothane is red. You don't need to know desflurane. And then I already told you, don't worry about these percentages. Go by the percentages that I put in that separate handout, okay? When using the vaporizer, again, to turn it on, well, first of all, I turn on my oxygen to my patient. I push the button and I turn the dial to my desired, remember I said a lot of times on ISO, I start at 2%. So I'll push down the dial, turn it to the 2 to deliver 2% of anesthetic, and percent is if I ask you what are vaporizers measured in, they're measured in percent. And we're going to check those levels before we start the procedure. So now normally what you guys do in surgery, when you're the anesthetist, when you go in the morning, you're going to hook up, you're going to choose your breathing system and your bag for your patient. You have to calculate all that. And then you'll hook up your systems, you'll leak test your machine, make sure there's no leaks, and you'll check your vaporizer. So ideally you're checking it when you're checking your machine. This shouldn't be like in the middle of the procedure, oh, I need anesthetic. So you want to check it before you start. Don't overfill, because again, that can affect how the vaporizer works. If you overfill it, it can cause damage, and then you don't want to underfill it. There is some notes here about maintenance, but again, I put a lot of these notes about, I want you to use my guideline in the notes, like what percent do you start at? How do I make adjustments? How do I know whether to turn them up or turn them down? Okay, and then here is a close-up of that window. So again, you can kind of see, maybe you can see in this picture, there's a faint line that's full. There's a faint line down here. Sometimes when it's right at that line, sometimes it's hard to see. Sometimes I have to kind of shake it a little bit and then I can see the line move. But it's not in this picture, but this is where you want to fill it. Now, if this happens, you want to pour very slowly. Sometimes it'll kind of bubble up and some of it will drop. Ideally, you want to leave the room, because I've had people where they've spilled anesthetic or they've been exposed and they start to get dizzy and woozy. You will get exposed to this and you can get sleepy. If you have a spill, ideally you are supposed to, ventilate the area. Like I said, if you spill it, you can go get a towel and paper towels, but I'm going to bet you by the time you get back, it's almost going to be gone because it's going to vaporize. But if you go in that room, remember the amounts, in open air, ISO can get to 30%. So ideally you would maybe put a fan in there. Not everybody has a window in the room that has the machine, but you need to ventilate and you need to kind of get out of the area for at least a half hour or so. So if you're filling this, hopefully no patient's attached, because then you can't really leave a room with your patient in there. But you definitely want to make sure that, because again, you could pass out, you could become woozy. Sometimes people get nauseous by the smell. So you do want to be careful. One thing also to be aware of is that it can get leakage if it gets shaken too much or tipped over. This is, and I can't stress this enough, is a lot of times you will roll an anesthetic machine to different rooms. I've done it in surgery. Sometimes I roll it into a classroom and I bring it back into surgery. But if you hit like a door jamb and it tips or falls over, again, it can get damaged and you definitely have to tell somebody because it can damage the inside. You might deliver unsafe amounts. And again, you might not want to fess up to that, but for the safety of your patient, you have to let someone know that it tipped. A lot of clinics, there's a couple companies. There's one called Vetamac, and Vetamac was a company started by my anesthesia instructor when I was at Purdue. His name is Harry Latshaw. He's like a legend in veterinary anesthesia, but he started a company, and now it's in several states. It started in Indiana, but they come about every 6 months and they check our machines. They check they verify that they're delivering the percent. They check all the gaskets and all the parts and, just kind of make sure your machines are working. So most clinics have a service contract that, someone can come out. Sometimes you have to take off the vaporizer and ship it. Sometimes places will come and fix it in the clinic. So it just kind of depends on your clinic's arrangement. But definitely have to tell somebody when you fill it, ideally you have an open air environment, but most of the time we're in a closed room. You just want to close it fairly quickly and cap your bottle. Again, if you forget to cap your bottle and you set an empty bottle on the counter, it's going to be gone. And one thing I neglected to mention when I was talking about the individual anesthetics is SIBO is more expensive than ISO. There's a lot of clinics that probably won't have SIBO. You guys will use it in surgery, but when you go to practice, there's a lot of clinics that they just use isoflurane. And some clinics will have both. But sevoflurane will get cheaper. It's a newer agent, so it is a little more expensive right now than isoflurane. But it will come down. So you don't want to waste any of these drugs because, there is a fair expense if you leave them open. And then the outlet port, I usually call it the outlet of the vaporizer. I don't call it the common gas outlet. I call it there's the inlet of the vaporizer is where oxygen comes in. The outlet of the vaporizer is where oxygen and anesthetic leave. It is connected to the breathing circuit. I showed you that black tube. There's a black tube and it'll go to a little port, and when that'll deliver, and that's usually near the inhalation valve. So when the patient inhales, they're taking in oxygen and anesthetic. And again, vaporizer out of circuit, there's usually just a tube that connects not in the breathing circuit, but kind of connects and delivers it into the breathing circuit. Now at the outlet port, it is connected there by a common tube and usually like it's showing you, it says there's like a male connector, but normally you don't have to mess with that tube. I'm going to be getting into breathing circuits when we do anesthetic equipment in anesthesia too. And that's when you deal with, how to hook up a non-rebreathing system, and that hooks up a different way to the outlet of the vaporizer. So there is a little bit of a difference in the connection if you're using one of the different breathing systems, but we'll get into that when we get into anesthesia too. So I will stop here for now. Do you have any questions? What I think we will do, and